بسم الله الرحمن الرحيم. السلام عليكم طلبتنا الأعزاء. Our last lecture regarding the gastrointestinal tract, colonic lesions, tumor-like lesions, polyps and tumors, and small intestinal tumors will be discussed in this lecture. Really, fresh food rich in antioxidant is essential for colonic health. Colorectal polyps. Polyps in general are any protrusion, as we discussed previously in the stomach. Polyp, any nodule or protrusion above the mucosal surface. In the rectum, in the colorectum, it is also an overgrowth of epithelial cells, the lining epithelial cells of the colon and rectum. Overgrowth of epithelial cells. Usually benign, the majority are benign and can turn into malignant according to the type, according to the factors and parameters will be discussed soon. The types of colorectal polyps. They are classified into two major types, non-neoplastic polyps, and neoplastic polyps. So the non-neoplastic polyps are from the name that those polyps that have no malignant potential in the future and are fortunately the commonest type of polyps in the colorectum, although the percentage of neoplastic polyps are higher than in the stomach. To start with, inflammatory non-neoplastic polyps are classified into inflammatory polyp, hyperplastic polyps or serrated polyps, and hamartomatous polyps. The first one is inflammatory polyp. Inflammatory from its name, it is developed on a background of chronic inflammation, repeated cycles or chronic cycles of injury and healing process result in polypoidal masses of inflamed mucosal tissue, like in the in inflammatory polyp and lymphoid polyp in chronic atrophic gastritis and so on. Repeated cycles of chronic inflammation result in polypoidal mass or projection of the inflamed mucosa. There is an entity called solitary rectal ulcer syndrome. Solitary rectal ulcer syndrome. Also, it is related to mild inflammation in the wall of the anterior rectal wall and characteristically associated with mucus discharge and bleeding per rectum in these patients. Hyperplastic polyps, or called also serrated polyp, because of the internal surface or internal lumen of the gland forming the polyp is are hyperplastic and with intraluminal enfolding forming a saw-tooth appearance or serration. يعني هيجي serration مثل المشرشبة أو مشرشرة serration hyperplastic like a sawtooth or appearance or so on. It is related to, it is common in adults or in elderly. It is related to delayed shedding of the surface epithelial cells in elderly with pulling or pile up of goblet cells. It is also very common and found in adults more than 60 years of age. Grossly, it is seen as a nipple-like or hemispheric protrusion, hemispheric or dome shape مثل القبة there is a picture in your textbook to see it. It can be multiple also, and most commonly more than one half in the rectosigmoid. Microscopically, as in this picture, hyperplastic gland lined by hyperplastic cells with crowding or luminal infolding like a sawtooth, so it is called serrated polyps. And the lining cells are absorptive cells, goblet cells, and have no malignant potential, very rare to become malignant. Hamartomatous polyps are rare, formed of two main types: juvenile polyps in children and adolescents, and Peutz-Jeghers polyp in patient with Peutz-Jeghers syndrome. Hamartomatous polyp, from its name, mean formation or aggregation or collection of normal tissue in an abnormal site. Juvenile polyp, to start with, they have no malignant potential, and effect from its name, it occurs in children and younger than 5 years, and also it can be solitary usually and most frequent in the rectum, may be presented with mild bleeding or constipation or mucus discharge from the rectum. And if it is found in adult, it is called retention polyp. Retention polyp, this is the name for juvenile polyp in adult, the same morphology. Usually small and less than 1 centimeter length. As in this representative picture, it is made of cystically dilated gland filled with mucin. The gland are dilated, filled with mucin, with surrounding inflamed stroma, and sometimes there is surface ulceration. Peutz-Jeghers syndrome or Peutz-Jeghers polyp, it is inherited condition, mainly seen in which polyps are seen in the small intestine, stomach, and colon. The shape of these polyps are large with herborizing pattern like a tree. And the smooth muscles in this polyp will splay upward into the mucosa, from the muscularis mucosa into the mucosal surface. It is called syndrome, in which the patient also have associated mucocutaneous hyperpigmentation. Mucocutaneous hyperpigmentation or melanotic spots in the mouth, in the skin, in the mucosal buccal mucosa. And patient with Peutz-Jeghers syndrome is at risk of several malignancies. Peutz-Jeghers polyps are not malignant by themselves, but patients with Peutz-Jeghers syndrome have an increased risk of malignancy of other organs like the colon, pancreas, breast, lung, ovary, uterus, and testes. So, increased risk of malignancies of extracolonic organs, other extracolonic organs, not the polyp themselves. So, they are non-neoplastic polyp of hamartomatous type. Peutz-Jeghers syndrome, patient with Peutz-Jeghers polyp. This is what we call it tree-like or herborizing pattern of the polyp in Peutz-Jeghers type of hamartomatous polyp. The splaying of the muscularis mucosae into the upward in between the glands into the lamina propria, with dilated capillaries, and so the characteristic tree-like or herborizing pattern. It is called syndrome when it is associated with other mucocutaneous pigmentation, melanotic spots of the skin, and the mucous lining surfaces, with increased risk of malignancies of other organ. The second type, or the type that requires specific and significant follow-up, that is the neoplastic polyp. From the name, neoplastic polyp means these polyps can progress to malignancy. By themselves, they are neoplastic in origin. They are adenoma from the start. So they are called adenomatous polyps or colonic adenomas. Adenomatous polyp or colonic adenomas. And they are caused by mutation in the tumor suppressor gene, APC, adenomatous polyposis coli. So mutation in this tumor suppressor gene will result in formation of these, and is seen in this type of polyps, adenomatous polyp. This mutation will result in acceleration or encourage the cell division of epithelial cells, and epithelial dysplasia are found within the polyp itself. So the polyp result in polyp formation and dysplastic changes. Dysplastic epithelial changes, mild, moderate, and severe dysplastic changes, and even can progress to invasive adenocarcinoma. So again, so it is required, it is at the start, requires mutation in other tumor suppressor gene. The first one that is mutated is APC, but is not enough for malignant changes. So it is a matter of accumulation of mutations, not single mutation. Accumulation of mutation over the time, over many years, not only APC. So APC is early mutated tumor suppressor gene, whereas KRAS and P53 are late mutated tumor suppressants. That are required for the adenoma to progress to invasive colorectal cancer. Again, it is a matter of accumulation of mutations. So the process of carcinogenesis in this adenomatous polyp is cumulative. It is cumulative. More than one mutations or hit in the tumor suppressor genes are required to develop invasive cancer. Generally, the classification, the types of this adenomatous polyp or colonic adenoma, so it is called adenoma, it is tumor or neoplastic from the start. Adenoma is a tumor of epithelial tissue. Classification, it is classified into three morphological or architectural types. Tubular adenoma or adenomatous polyp. It is tubular, mean formation, there is formation of glands, glandular formation. It is pedunculated. Pedunculated mean presence of neck or peduncle or stalk with a tree-like or cauliflower-like shape. It is very common. And the other type is villous adenoma. Villous adenoma, from the name, it is formed of finger-like projections. This here is sessile, not pedunculated, without stalk, and less commonly seen, mixture of both tubular and villous adenoma. There is equal percentage of both tubular and villous adenoma architecture in the same tumor. It is called tubulovillous or villoglandular, the same. But the most commonly seen is tubular adenoma. So tubular adenoma or adenomatous polyp, tubulovillous, mixture of both, and villous adenoma with sessile appearance. This is the sessile polyps and the adenomas. A hyperplastic polyp are made of hyperplastic colonic glands, whereas adenoma, there is proliferation of the gland with dysplastic changes. And here the adenoma is seen as pedunculated. This is the pedicle or stalk connected or forming a tree-like or cauliflower-like, whereas the sessile or villous adenoma containing no stalk and is made up of serrated or finger-like projections. Again, all adenomas are show dysplastic epithelium from the start, and they are precancerous, or all adenomas are precancerous or pre-malignant, and the changes or the progressing changes to develop cancer is a matter of time. So strict follow-up and screening, colonoscopy is very essential to detect any focus, and biopsy to detect any focus of malignancy or invasive cancer. It may proceed or progress to invasive carcinoma, may occur anywhere, mostly in the left colon, especially in the rectosigmoid colon. The malignant transformation, the risk of malignant transformation for each polyp, for each adenoma is dependent on three parameters that are influence the malignant potential, the malignant progression of the tumor. Number one, the size, the polyp size. The larger the size, the more chance to become malignant. The architecture, villous adenoma having higher malignant potential than tubular adenoma or adenomatous polyp. And severity of dysplasia, polyp with severe dysplasia or moderate dysplasia is at higher risk of developing malignancy than polyp with early mild dysplasia. So again, the risk of malignant transformation is dependent on three factors: polyp size. The larger the size, the more chance to become malignant. The architecture, villous more than adenomatous polyp, and severity of dysplasia. Advanced dysplastic changes are that polyp will rapidly grows to become malignant. Tubular adenoma here, multiple tubular adenoma. This is the largest one. This is a polyp, and maybe this is another one. And here, cancer or colorectal cancer develop in nearby or on a background of adenomatous polyp or tubular adenoma. Here, the size is regarded as large, about 3 centimeter length. Here it is 2 centimeter length, with pedicle or with a stalk connecting the cauliflower head of the polyp to the mucosal surface of the colon. And here, frank malignancy is developed in on a background of adenomatous polyp. Bleeding, necrosis, mass, infiltrative mass, ugly looking, infiltrating the surrounding mucosa. Tubular adenoma, the name is related to formation or related to the component of the tumor or of the polyp. It is made up of overcrowded neoplastic glands with features of dysplasia. So the glands are crowded, disorganized, regular in shape, and they are crowded with cells with dysplastic changes, including cellular overcrowding, stratification, hyperchromasia, and frequent mitosis is also can be seen on higher power and so on. High NC ratio, hyperchromasia, loss of polarity, stratification, crowding, and disorganized gland. Thus, mucosa is crowded by a large number of glands in adenomatous polyp or tubular adenoma. This is the gross appearance of villus adenoma. Villus adenoma, that is the sessile polyp, sessile neoplastic polyp without stalk. The tumor shows a serration of the surface, like a finger-like projections with superficial bleeding, spotty bleeding. This architecture or this type of tumor of adenoma is more likely to become malignant and more likely to show severe dysplastic changes in their gland or in their epithelium than adenomatous polyp. Although they are less common than adenomatous polyp, but they are more commonly to become transformed to malignant, to invasive cancer. This is the microscopy of villus adenoma. So the polyp is made up of villi, like the small intestinal villi or finger-like projections or leaf-like projections rather than tubular. So elongated finger-like projections is the architecture of villus adenoma. Higher incidence of dysplastic changes and progression to malignancy than tubular adenoma and even mixed tubulovillus adenoma. There are colonic familial syndromes. Familial syndromes, they are called syndromes because in addition to colonic lesions, there are other extra colonic manifestations and features. The commonest will be discussed: familial adenomatous polyposis, Gardner's syndrome, and juvenile polyposis syndrome. Familial adenomatous polyposis. Polyposis. It is an autosomal dominant inherited condition. So family history is important in this type of familial syndrome. And when one member of the family is discovered to have familial adenomatous polyposis, other members, especially the first degree relatives, should be screened by screening colonoscopy for prophylactic total colectomy to even at early adolescent life because of very high chance to develop malignancy in these numerous type of adenomatous polyp in these patients. that hundreds and thousands and even thousands of adenomatous polyps are required for the diagnosis of familial adenomatous polyposis. At least 100 of adenomatous polyps are required for the diagnosis of familial adenomatous polyposis. There is a picture show. This is the colonoscopy of patient with familial adenomatous polyposis. Showed you the replacement of the colonic mucosa by numerous innumerable غير معدودة number of adenomatous polyps. So the lining mucosa or the lining surface of the colon is transformed into carpet of numerous or innumerable or huge number of adenomatous polyps. The cause of development of this type of syndrome is related to germ-line mutation of adenomatous polyposis coli gene, that is a tumor suppressor gene preventing apoptosis. The mutation of this tumor suppressor gene will result in cellular overgrowth and polyps, many polyps formation. The important risk factor again is positive family history. The most severe complication or ominous complication is malignancy development of invasive colorectal cancer in early adolescent life. Multiple gastrointestinal adenoma in the stomach, in the small bowel, and even Fundic gland polyps in the stomach. And also there is a risk of malignancies of other organs, extracolonic organs, like in the thyroid or pancreas, brain, gliomas of the brain, in the liver, hepatoblastoma of the liver, and so on. So it is called syndrome because of, in addition to numerous huge number of adenomatous polyp of the colon, there is also an Fundic gland polyp and increased incidence of malignancies of other parenchymal organ in the body. Carpet of huge number of adenomatous polyps. Malignancy can develop in any one of these polyps, so prophylactic total colectomy is required whenever it is discovered, because malignancy can develop at any time in any of these adenomatous or neoplastic polyps. The second syndrome is Gardner's syndrome. It is a variant of familial adenomatous polyposis with prominent extracolonic manifestations. Also, it is an autosomal dominant. Polyps, multiple adenomatous polyps in the colon, but there is multiple bone tumors, skin lesions, especially at the mandible, skull, and long bones, epidermal or epidermoid cysts in the skin, fibromas and fibromatosis in the abdomen, and also lipomas, mesenchymal tumors. So there is prominent extracolonic manifestation than in familial adenomatous polyposis, multiple bone tumors, skin lesions, and mesenchymal tumors, including fibromatosis and the retroperitoneum or another mesenchymal tumors like lipoma. Again, mutation in adenomatous polyposis coli gene, APC gene, RAS, P53 mutation, and DCC gene deletion result in progression of the polyp into malignancy, into invasive cancer. So again, the process of malignancy is a matter of accumulation of mutations over the time. Again, there is complication, including malignancy of other organ in the colon, thyroid, liver, and kidneys. Juvenile polyposis syndrome. Juvenile polyposis syndrome is the third familial syndrome. They are all inherited in families. Numerous benign polyps along the gastrointestinal tract. Majority are non-neoplastic hamartomatous polyp in the colorectum. They are non-neoplastic. They are hamartomatous, but they are not malignant by themselves. The polyps are not neoplastic by themselves, but the patient have increased risk of colorectal, colorectal and extra-colonic adenocarcinoma. Intestinal obstruction can be complicate this type of polyps, hamartomatous polyps. Malignancy, colonic malignancy or colonic cancer, colorectal cancer or colonic adenocarcinoma. This is a common type of malignancy of the large bowel and the rectum. It is the third most common cause of cancer worldwide after bronchogenic carcinoma, CA lung, and ductal carcinoma of the breast. Colorectal cancer stand the third in frequency after lung cancer and breast cancer. The tumor arises from the epithelial tissue, from the epithelial lining cells. Adenomatous polyp formation is very common preceding event which will progress to adenocarcinoma. The tumor is highly metastasized or have high metastatic potential after penetrating the muscularis mucosa to penetrate the wall and adjacent organ or mural lymph nodes or even distant metastasis. It is a disease of late adult life. Peak incidence is 60 to 70 years. Familial adenomatous polyposis patient either inherited one defective copy of APC gene. This is called one-hit inheritance during embryogenesis, and the remaining normal APC allele in the colonic stem cells is the necessary to loss of this normal APC allele in the colonic stem cells is required for the adenoma to start and progress to invasive cancer. Genetic alterations or the genetic or molecular changes started from normal into invasive cancer. There is a table or diagram to represent these molecular changes of colorectal cancer. You can see it in your textbook to clarify these cumulative mutations. APC gene is an earlier change, as we say. APC mutation acts as an anti-proliferative tumor suppressor gene, regulating the destruction of beta-catenin. With the loss of this tumor suppressor gene, APC, there will be accumulation of beta-catenin. it will not be destroyed, and it will translocate it to the nucleus and give a signaling act as a growth promoting transcription factor, stimulate cell growth and proliferation. This neoplastic progression will be associated in the advanced stages with other tumor suppressor gene mutation like SMADs and other KRAS and P53 are late changes. So all of them can be accumulated in normal cells and inhibit, and these tumor suppressor genes, those inhibit cell continuous cell cycle. It will be mutated, and this will result in progression of adenoma to invasive cancer. Risk factors of colorectal cancer. The risk factors. There are many risk factors. Firstly, hereditary factors, especially in patients with familial adenomatous polyposis. Inflammatory bowel disease, specifically ulcerative colitis and Crohn's disease, with higher incidence of malignancy in ulcerative colitis than in Crohn's disease, as we say previously. Lifestyle, unhealthy lifestyle, tobacco smoking, lack of physical activity, dietary bad habits like alcohol consumption, processed meat or processed red meat, and low consumption of vegetables and fruits, and especially so it is a disease of low socioeconomic status related to consumption of canned food and unfresh and deficiency of fresh food like vegetables and fruit rich in antioxidants. Obesity is another risk factor. Diabetes mellitus is a risk factor also, in addition to insulin resistance. Both are risk factors. Again, low socioeconomic status related to poor nutritional deficiency, antioxidant deficiency, eating or consumption of canned food rich in food preservatives, and salted, pickled, processed meat, skimmed meat, and so on. These are bad. A history of abdominal radiation. History of abdominal radiation is also a risk factor for colorectal cancer. Abdominal radiation, like X-ray for any condition like treatment radiation or diagnostic X-ray imaging. Lack of screening colonoscopy. Screening is very essential in late adult life to pick up any colonic adenoma or mucosal abnormality and take frequent biopsy. So screening is important, lowering the complications and help to detect the earlier stages of colorectal cancer, because most commonly the disease is asymptomatic in earlier stages, unless it is sometimes causing intestinal obstruction, reaching a huge size to cause intestinal obstruction. Black male are also at higher risk of colorectal cancer, and the disease is increased. The risk of colorectal cancer is increased with advancing age. Signs and symptoms. The signs and symptoms of colorectal cancer can be variable. Sometimes it is asymptomatic initially unless the tumor enlarging, infiltrating the wall, causing intestinal obstruction, causing bleeding per rectum. So earlier diagnosis, earlier or called screening colonoscopy is very essential. It is routine procedure done in the Western countries. Vague constitutional symptoms, including general symptoms of cancer, including anorexia, fatigue, and weight loss. Changes in bowel habits, alternating constipation and diarrhea. Rectal bleeding. Rectal bleeding can be frank bleeding or fresh blood per rectum, or it can be occult. Occult is in which the blood cannot be seen by naked eye, and it also can it is detected by microscopical or certain laboratory test called stool Guyach test. This is for occult blood in the stool. Occult means microscopical RBCs or microscopical bleeding or silent bleeding, which is responsible for iron deficiency anemia in these patients. Rectal pain, vague rectal pain, tenesmus, feeling of incomplete defecation, nausea and vomiting, and bowel obstruction. So the features or the signs and symptoms are variable and can give a hint for the type and location of the tumor. There are certain laboratory testing in which a tumor marker carcinoembryonic antigen. Carcinoembryonic antigen is very high. It is estimated in the serum of the patient. And stool Guyach test is positive for occult blood. It is responsible for iron deficiency anemia because of chronic blood loss in adult male. So iron deficiency anemia in adult male should be taken seriously. There are certain differences between left-sided and right-sided colonic adenocarcinoma, including the morphological gross appearance, including the type of symptoms, signs, and presentations, and certain signs. The left colonic adenocarcinoma in general, left colonic adenocarcinoma, generally annular. Annular means it is constricting, حلقي, annular حلقي, like a ring. Here, the presentation of left colonic adenocarcinoma is earlier than right colonic adenocarcinoma because the tumor is constricting, causing intestinal obstruction. So the patient comes to the hospital and come with the change in bowel habit and signs of intestinal obstruction and abdominal cramp and discomfort. And also blood can be seen in the stool, occult or frank, whereas right colonic adenocarcinoma usually diagnosed later, usually asymptomatic and be asymptomatic for a long period of time. It is one of the presentation is iron deficiency anemia due to surface ulceration of the tumor and bleeding and blood loss. The tumor is polypoidal, fungating, so the tumor when the tumor reaching larger size, so it's causing intestinal obstruction, and the patient can seek medical advice. The tumor is non-obstructing. Non-obstructing, the tumor is polypoidal or exophytic into the colonic lumen. This is a type or the gross appearance of most commonly cancer seen in the right-sided colonic adenocarcinoma. It is exophytic or fungating or polypoidal. Here the mass is regular, ugly looking, with central necrosis and bleeding, surrounded by normal mucosa. Here the tumor must reach a large size to causing obstruction. So the tumor can grow within the lumen without obstruction. And it is associated with that comes or discovered late in advanced stage. And the right colonic adenocarcinoma, whereas in the left colonic adenocarcinoma, left-sided colonic adenocarcinoma, the tumor is annular or constricting. Here, there is the tumor is grow within the wall, grow into the wall, not fungating. It is called annular halaqi or constricting or napkin-like or apple-eaten. The tumor here is discovered earlier. It is a characteristic growth pattern in left-sided colonic cancer in the descending colon. The patient here is coming to the seeking advice and complaining of features of intestinal obstruction, abdominal gases, abdominal cramping pain, and so on. Whereas in the right-sided, it is discovered late. The patient is usually asymptomatic, and iron deficiency anemia is the commonest presenting feature. So again, iron deficiency anemia in an elderly man should be taken seriously, not like in women because of monthly menstrual loss. So iron deficiency anemia in women is can be considered or can be as common presentation, whereas in man or in adult male or it is unusual. The microscopical appearance is adenocarcinoma. The tumor is still forming glands, although they are malignant in features, areas of atypia, irregular glands, disorganized gland with the high mitotic activity, dysplastic changes, high NC ratio, hyperchromatic cells here in comparison with the glands on the left side of the picture. Here they are non-neoplastic glands, whereas the neoplastic gland showed overcrowding, hyperchromasia, irregularity, distortion, and ugly-looking glands, infiltrative glands. For each tumor, not only the rectal tumor or colorectal tumor, there is a grading system and staging system. Very important for the prognosis, very important for the treatment and management. Grading is the degree of similarity of the tumor to the tissue of origin, graded into well, moderate, and poorly differentiated. as far as the tumor is well differentiated, the prognosis is better, the treatment, the response to treatment is better, and the 5-year survival rate is better. Whereas the poorly differentiated tumor, it is associated with bad prognosis and bad response to treatment. Whereas the staging, the common staging or the standard staging system used is the T&M staging. And there is another staging for colonic cancer called the Duke staging. Commonly, T&M indicate or represent T for tumor, N for node, and M for metastasis. T, this is represent the characteristics of the tumor itself, the size of the tumor, the invasion of the nearby tissue, fixation, and so on. Whereas the N is related to nodal involvement of regional lymph node, like in the colon, involvement of the lymph node in the wall of the colon. With M represent distant metastasis, spread of primary tumor into other body parts, especially the lung, bone, and liver. Portal circulation is a common site for metastasis in colorectal cancer. This is a diagram showed the stages of colonic cancer. Stage 0 is intramucosal. The tumor is within the mucosa. Stage 1, the tumor infiltrating the mucosa and submucosa. Stage 2, the tumor penetrating the muscularis propria without lymph node involvement, whereas stage 3, the tumor penetrating through the muscularis propria with nodal involvement, with mural lymph node involvement. Mural معناها lymph node within the wall of the colon. Mural lymph node involved. So stage 3 requires stage 3 classification requires positive mural lymph node metastasis or permeation or involvement of the lymph node in the wall of the colon. And finally, stage 4 is distant metastasis to the lung, to the liver, through portal circulation, to the brain, to the lung and bone, and so on. The prognosis is closely related to the depth of invasion, as I say, mucosal and submucosal, penetrating the muscularis propria and reaching the mural lymph node, and also presence of lymph node metastasis. Okay. Regarding neoplasms of the small intestine, in general, neoplasms of the small intestine is less common than those of the large intestine. They are generally classified into benign and malignant. Benign including adenomatous polyp, but they are less common than gastric and colonic adenomas. Leiomyomas, smooth muscle benign tumor, lipomas, and angiomas, benign vascular involvement. The malignant adenocarcinoma of the small intestine is also less common. Carcinoid tumor of neuroendocrine cells within the lining epithelium of the small intestine. Lymphoma can be seen in the small bowel and sarcomas. To specify certain types of tumors in the small intestine. Carcinoid tumor not only occurs in the small intestine, can occurs in the stomach, in the appendix, in the rectum, colon, sigmoid, and so on. Carcinoid tumor, it is uncommon tumor, but is well differentiated, slowly growing. So it is called carcinoid or carcinoma-like because these tumors are slowly growing and usually or well differentiated, especially in certain types or certain anatomical types, especially the appendiceal and rectal carcinoid. They are usually slowly growing, benign behavior with well differentiated in general. They are of neuroendocrine origin. The cells in the digestive tract. Also, this tumor or these cells can be found in the bronchopulmonary system and genitourinary tract. Neuroendocrine cell tumor is called carcinoid tumor, whether in the gastrointestinal tract, in the bronchopulmonary system, and genitourinary tract. It can be benign or malignant and with tendency for liver metastasis in certain types and locations. So these tumors, many of them are well differentiated, slowly growing, and with benign behavior. Others are aggressive, especially the ileal carcinoid. But in general, they are less aggressive than gastrointestinal tract adenocarcinomas, so they are called carcinoid. With low grade and low mitotic activity and indolent course. The types of carcinoid tumor, they are classified into three types or three types according to the location, according to the origin of these tumors, into foregut carcinoid tumor, midgut carcinoid tumor, and hindgut carcinoid tumor. The foregut carcinoid tumor, including carcinoid arising in the stomach, arising or originating from enterochromafin-like cells, neuroendocrine cells. And the midgut, small bowel, originate from intraepithelial endocrine cells. Commonly in the midgut is located in the ileum and can arise from Meckel's diverticulum with potential for lymph node and hepatic metastasis. So ileal carcinoid can have the potential for lymph node metastasis and hepatic metastasis. Can behave in aggressive way, especially in the ileum, midgut carcinoid. The appendix, the appendiceal carcinoid, is usually well differentiated, slowly growing, and discovered incidentally. Can be presented as with signs and symptoms of acute appendicitis, in which the tumor here obstructing the lumen of the appendix, causing luminal obstruction and inflammation of the wall of appendix. Again, it is originating from the subepithelial endocrine cells of low malignant potential and low potential for metastasis. So appendiceal and rectal carcinoids are never metastasized and are usually of low, slowly growing. Hindgut, the third type, hindgut carcinoid tumor affecting the rectum, colon, and cecum most commonly. Again, appendiceal and rectal carcinoid almost never metastasize, whereas the ileal or terminal ileum Carcinoid are more aggressive, can be associated with lymph node metastasis and hepatic metastasis. The complication of carcinoid tumor. There are local complications and local and distant metastasis. Local means infiltration of nearby structure or nearby tissue, local invasion, and distant metastasis, especially for small intestinal ileal carcinoid, pain or crampy abdominal pain due to obstruction or due to intussusception or bowel ischemia or mechanical pressure by the tumor itself. Carcinoid syndrome in which there is symptoms related to humoral factors that are hormones or chemical materials secreted by the tumor itself, like serotonin, histamine, so result in certain manifestations, signs, and symptoms related to humoral factors, material secreted by the tumor itself, like serotonin, histamine, and other neuroendocrine material, secretory material, result in cutaneous flushing or hotness or red cutaneous flushing or flushy attacks of the face or the hand, and pruritic rash or itchy skin, excessive lacrimation and wheezing or asthmatic wheezing. So there is a mnemonic summary for the syndrome component. Carcinoid syndrome component are CARS for carcinoid, from carcinoid, CARC, cutaneous flushing due to secretion of histamine and serotonin, asthmatic wheezing, right-sided valvular heart lesions. These patients may have certain valvular stenosis or changes in the heart, and these heart lesions associated with especially right-sided valvular heart lesions, and cramping abdominal pain and diarrhea. Cramping abdominal pain and diarrhea due to this humoral secretory material. This is the small intestinal lumen, and mass is seen within the lumen here, obstructing the lumen. It is related to small intestinal carcinoid, terminal ileum, obstructing the lumen. It can form a polypoidal mass or solid mass, tan-colored, tan يعني لونها أسمر, microscopically made of islets and trabeculae, nests, cords of cells. They are monotonous uniform cells with granular cytoplasm. monotonous يعني وحدة تشبه الأخ، يعني ما بيها بليومورفيزم، عكس البليومورفيزم. monotonous uniform يعني regular cells with granular or نسميها stippled cytoplasm or يسموها pepper and salt cytoplasm, finely granular cytoplasm. IHC, immunohistochemistry for the tumor, it is positive for neuroendocrine markers. Positive for neuroendocrine markers, including chromogranin, neuron-specific enolase, and synaptophysin. This is the pattern of growth or the microscopical pattern of cells. The tumor is forming nests. These are nests and cords and acini or trabeculae of cells. The cells are similar to each other. They are monotonous and uniform with finely granular cytoplasm, stippled chromatin granularity, low-grade tumor, well differentiated and slowly growing, except for the ileal carcinoid. It can behave in a more aggressive manner. The stroma is separating nests of tumor cells. This is a similar carcinoid tumor involving the lung tissue, lung parenchyma. This is the tumorlets or islets of carcinoid tumor, and here the compressed surrounding pulmonary alveolar spaces here, and the tumor is here seen made up of these uniform monotonous cells, carcinoid tumor of the lung, or as we say in the bronchopulmonary system, and the genitourinary tract also. Whenever neuroendocrine cells are present, this type of tumor can be originate. Another small intestinal tumor or even can be seen along the gastrointestinal tract, esophagus, stomach, small intestine and large bowel. All these sites can be affected by gastrointestinal stromal tumor, or called GIST. Gastrointestinal stromal tumor. From its name, the name can give you a hint for the origin of this tumor. It is originate not from the epithelial cells like in adenoma and carcinoma, not originate from neuroendocrine cells like in carcinoid tumor. It is originate from interstitial cells or stromal cells. It is called interstitial cells of Cajal. They are uncommon tumors. They arise from the wall of the bowel. It can be presented as intestinal obstruction, protruded into the lumen as a polyp, or can be ulcerate with GIT bleeding. It is in general, it is slowly growing and should be or can be cured by surgery. Recurrence can be seen in 30% of cases with liver metastasis within 10 years. Is it benign or malignant? Gastrointestinal stromal tumor, is it benign or malignant? It is different according to the behavior of each type of tumor. Starting from normal leiomyoma, so according to the behavior, the tumor is classified according to the behavior. If there is invasion, if there is this local recurrence, local invasion, if there is frequent metastasis or active metastasis, if there is areas of necrosis, so the behavior of the tumor will determine whether it is benign or malignant. So metastatic tumor or metastatic carcinoid indicate that it is malignant, whereas most of them are benign in behavior. This is the lining mucosa of the bowel with presence of this polypoidal or projecting mass. It is originating from a stroma or from the interstitium. Can be the stroma containing the stroma of the colonic wall, containing smooth muscles, containing fibroblasts, containing neural cells. So GIST or gastrointestinal tumor can be classified into fibroma or fibromatosis, leiomyoma if it is benign, and leiomyosarcoma if it is malignant, neurofibroma, and so on, according to the origin of the tumor, of the interstitial or stromal tumor from which the tumor arises. This is the microscopical appearance of gastrointestinal stromal tumor. Here the tumor, so as I say, can be the type is according to the cell of origin, whether it is smooth muscle cell, fibroblast from the stroma, from lamina propria, or neural cells. يعني النeural cells, perineural cells from the neural plexus within the muscles and mucosa. Here the tumor is made up of smooth muscle cells, characteristically seen as such with rounded ends. عادة الفايبروبلاست تصير tapered end مدببة الحافات. Here the smooth muscle cells are associated with, shows rounded edges called cigar shaped or sausage shaped nuclei. Nuclei are cigar shaped or sausage shaped rounded end rather than spindle or rather than tapered like in fibroblast. This is the longitudinal cut section, and here cut section of these smooth muscle cells. Gastrointestinal stromal tumor mitosis can be, so as I say, the type, whether it is benign, intermediate, or malignant, it is depends on the behavior of the tumor itself, whether there is local invasion, distant metastasis, frequent mitosis, atypia, and so on. But most of them are benign behavior. Show benign behavior. Lymphoma or primary lymphoma of the small intestine, and also can affect the stomach and colon. Primary lymphoma, not secondary. Most of all lymphomas or all primary lymphomas affecting the gastrointestinal tract. As you know, lymphoma are classified into two major types: Hodgkin lymphoma and non-Hodgkin lymphoma. So all extranodal lymphomas affecting the gastrointestinal tract and affecting the bronchopulmonary system are non-Hodgkin lymphoma. يعني ما عندنا Hodgkin lymphoma بالgastrointestinal tract. It arises. What is the origin of this primary tumor? What is the origin? It arises from the lymphoid aggregates or from Peyer's patches or from mold tissue, mucosal associated lymphoid tissue, which act as a part of the protective of the immune system of the bowel. Gastric lymphoma are most common and have better prognosis. Usually gastric lymphoma are low-grade lymphoma with better prognosis and even of better prognosis than gastric adenocarcinoma of both type, diffuse and intestinal. Gastric lymphoma or gastric maltoma is of favorable prognosis than gastric carcinoma. And also gastric lymphoma has better prognosis than small intestinal or large intestinal, especially in the earlier stages of detection. Certain type of lymphoma, of primary lymphoma, من نقول primary يعني the tumor is originating within the wall of the bowel by itself and not metastasized from other site. There is هذه سابقا ذكرناها refractory or celiac sepro associated T-cell lymphoma. Also it is called enteropathy. هذا WHO classification. WHO classification this type of lymphoma is called enteropathy associated T cell lymphoma. It is a bad lymphoma, a primary lymphoma or T cell lymphoma of bad prognosis. It is the long-standing complication of celiac disease. Patient with long-standing celiac disease or gluten-sensitive enteropathy may develop this type of primary lymphoma as a result of a long-standing continuous stimulation of T cells in the small bowel. This complication can happen after 15 to 20 years in patient with the chronic celiac disease with poor control or poor patient with without withdrawal or bad with patient with poor control of his disease. It is called enteropathy associated T cell lymphoma or refractory celiac lymphoma. It is a type of T cell lymphoma. Again, MALT lymphoma or maltoma. This is the low-grade type of favorable prognosis affecting the stomach, most commonly, and also can affect any part, and can affect the small and large bowel also, but to a lesser extent. هذه البرسنتج مو شرط تعرفوها، فقط إنه most commonly affecting the stomach and less commonly affecting the small and large bowel. It forms up to 1 to 4% only of all gastric malignancies and early adult life patient. So maltoma is a low-grade lymphoma, low-grade primary lymphoma. The other type again is number 2 is enteropathy associated T cell lymphoma, or called lymphoma of long-standing malabsorption syndrome, especially gluten-sensitive enteropathy, and duodenum most commonly. It is also of T cell origin. It is called T cell lymphoma. Mediterranean lymphoma. This is a B cell type. It is of higher grade and poor prognosis, in which there is a high number of plasma cells infiltrating the small bowel wall and affecting children and young adults, so bad prognosis. In addition, the fourth type is Burkitt lymphoma. Burkitt lymphoma is also primary lymphoma of high grade, affecting children and young adults, with also can affect the retroperitoneal lymph node and ovaries also. Acute appendicitis, diseases of the appendix. The commonest or the commonest disease or disorder of the appendix is acute inflammation. Acute appendicitis, usually it is a disease of young people. The obstruction is usually or classically by a fecalith, and in which it is causes obstruction of the lumen and lymphoid tissue hyperplasia, and obstruction and suppurative inflammation of the wall. Sometimes it is obstructed by another objects like undigested fruit seeds. Here there is a cut section from the tip of the appendix, and this is the base. The appendix here shows the fibrin deposition and edema and swelling of the wall. Neutrophils are required to be seen in the muscular wall. Usually it is present in the mucosa, But for diagnosis of acute appendicitis, we require neutrophils, large number of neutrophils, to be seen in the muscular coat. If untreated or not resected surgically, rupture and peritonitis and perforation and peritonitis can be complicated. Here, the wall of the small bowel is the normal wall, and here the wall involved or muscular coat for diagnosis of acute appendicitis. Large number of neutrophils should be seen within the muscular coat of the appendix. Tumors of the appendix, similar, or they are the same names or the same lesions can be seen within the pancreas and also within the ovary. Mucocele, that is benign dilatation, not a tumor, but it is a cystic dilatation filled with mucus secretion. Benign tumor called mucinous cyst adenoma. Mucinous cyst adenoma, cyst filled with mucin and lined by neoplastic cells, but they are benign. And there is dilatation with mucous material. This cyst may rupture and causing pseudomyxoma peritonei or rupture into the peritoneal cavity. If the lining epithelium of the cells shows invasion of the cyst wall, it is called mucinous cyst adenocarcinoma. Mucinous cyst with neoplastic cells infiltrating the wall of the cyst. It is the malignant counterpart called mucinous cyst adenocarcinoma. These names are seen in the pancreas and also seen in the ovary. A condition called pseudomyxoma peritonei is in which there is distension of the peritoneal cavity due to presence of semi-solid or jelly-like mucin containing adenocarcinoma cells. A rupture of these cysts from the ovary, from the appendix, from the pancreas, and also it is called pseudomyxoma peritonei, and these peritoneal seedings of malignant cells within the peritoneum, it is responsible after evacuation, it is responsible for tumor recurrence and infiltration of peritoneal organ and tissue by malignant cells. Pseudomyxoma peritonei. Lesions of the peritoneum or peritoneal lesions or diseases. The peritoneum is made up of two layers, visceral and parietal layers, lined by mesothelial cells. These are the mesothelial cells seen within the peritoneal fluid, or also can be seen in acidic fluid. Aspirate of this fluid can show the lining epithelium, mesothelial cells. They can react to inflammatory change, but in general they indicate benign reactive condition. They are benign. They are the sloughed lining epithelial mesothelial cells into the loom, into the cavity, into the peritoneal cavity. Peritonitis or inflammation of the peritoneal cavity, acute peritonitis can result from ruptured viscera, like ruptured or local rupture of appendicitis, rupture of peptic ulcer, rupture of acute cholecystitis, local or rupture, local inflammation, cholecystitis, or local diverticulitis, inflammation of the outer surface of the diverticulum, or rupture salpingitis, that is inflammation of the fallopian tube, gonococcal, bacterial, or chlamydial. So retrograde spread or perforation of these viscera can result in acute peritonitis or rupture of the bowel wall for any reason, distension, volvulus, intestinal obstruction, dissusception, rupture due to toxic megacolon in ulcerative colitis, and so on. Perforating abdominal wall injuries, penetrating trauma or penetrating injuries into the abdominal wall can causing peritoneal seeding of bacteria. Commonest bacteria are E. coli, staph, strep, and enterococci. The outcomes or the fate نتيجة of peritonitis, even either complete resolution after response to treatment and evacuation of the suppurative process, walled off abscess, formation of abscess around the viscera, around the inflamed organ, whether the tube, diverticulum, appendix, and so on, walling off. The body will form a fibrosis or wall of fibrous wall around the inflamed organ, or adhesions are very common. The most common outcome of peritonitis are adhesions or adhesion bands that can result in abdominal cramps or result in kinking of bowel loops. Adhesion is the most common complication of peritonitis. And thank you for listening. This is the last topics about gastrointestinal tract. Our next lecture is regarding accessory glands, the hepatobiliary system. Thank you.